Let's go to the next talk. It's again a case-based discussion. Approach to early allograft dysfunction. I invite the chairpersons, Professor Neelam Mohan, who is a professor and head of Department of Pediatric Hepatology at Vedanta Institute, Gurgaon, and Professor Neera Govind, who is the head of transplant surgery at Apollo Hospital, Delhi, to chair the session. Thank you. All to you, chairpersons.
Thank you. I would like to now get the session started on case-based discussion approach to early graft dysfunction. I would like to welcome the moderator, Dr. Dinesh Jyothimoni from Dr. Rela Institute and Medical Center, Chennai, and the other panelists as well. Dr. Unikrishnan from AIMS Kochi, Dr. Ajita Srivastav from Fortis Gurgaon, Dr. Mallikarjun Satpal from Aster CMI Bangalore, and Dr. Naveen Ganju from Sparsh Hospital Bangalore. Please, over to you, Dr. Dinesh.
Yeah, thank you.
Thank you so much for having us. Thank you so much. This is Neelam.
Can you see my screen?
Yes, please.
Thank you very much, LTSI and chairpersons, for this wonderful meeting. Today, we're going to talk about this case-based discussion, how to approach early allograft dysfunction. Let's go into the case. But before that, I just want to define what allograft dysfunction in the early postoperative period means. Can I ask one of the surgeons here in the panelists, probably Dr. Ajitab can start, what allograft dysfunction means to you? There are a few definitions in the literature, but what it means to you as a surgeon, please.
I think so, Dinesh. As per the definition which has been commonly used by Althoff et al., that there has to be at least one of the following parameters where at day 7, the bilirubin will be greater than 10, then INR more than 1.6, and at any point in time, the AST, ALT is more than 2000, which in a situation of a DDLT, at times we may find where AST, ALT may go up, but that would be one of the definition which I would commonly be considering for early allograft dysfunction.
Thank you. From the hepatology perspective, Dr. Naveen, do you think diagnosing early allograft dysfunction at day 7, is it too late? What do you think? What's your experience and opinion on that, please?
Yeah, of course, it is late, as early as possible so that we can take actions. As we always know, allograft dysfunction can be because of sepsis as well. So whatever we can diagnose as early as possible, because if there are any issues, let it be technical or sepsis or any other issues, earlier the better. This definition is always kept at 7 days, I think, because there is some things like ischemia, reperfusion, which settle by themselves, So then you actually have to see how the graft functions and how it proceeds further on so that you take actions. But of course, we can't wait for 1 week for things to get better.
Yeah, I think that's why we have this sort of other definitions which defines these patients and identifies them early so that we can act on them. Okay. So let's go into the case discussion. So we have a 59-year-old gentleman diagnosed with NASH end-stage liver disease, decompensated with hepatic encephalopathy and ascites. When he presented, his MELD was high, it's 24. He was obese with BMI close to 40. So he underwent evaluation for liver transplantation and his son was his potential donor. Past medical history, this gentleman was a diabetic on insulin and he had the previous hemorrhagic stroke, which left him with some hemiparesis but recovered. He was hypertensive, he was previous alcohol consumption and reformed smoker. During the evaluation for liver transplantation, most of his tests were fine, except in coronary angiogram, he had a 60% lesion in the left anterior descending. However, his stress test for inducible ischemia was negative. Donor details was a son as a donor, absolutely fit and healthy guy, BMI 23.7. It's a right lobe graft without MHV, and the graft weight was 755 grams. Intraoperative course, fairly straightforward anesthetic induction. Reperfusion was uneventful. His cold ischemic time was 100 minutes. Warm ischemic time was 20 minutes. His graft recipient weight ratio was 0.7. And everything went as per the plan. He received methylprednisolone and was commenced on piperacillin tazobactam and fluconazole. During transfer to ICU, his lactate was 5.1. He was on low noradrenaline support, and he was electively on elective ventilator support with adequate oxygenation. In the immediate postoperative course, he was off vasopressors in the next couple of hours and was extubated within 8 hours. And he received methylprednisolone and tacrolimus-based immunosuppression the following morning, and his renal function was optimal. So everything was quite smooth. However, the following day, his bilirubin started going up. As you can see, from 8.4 jumped to 15.8 and then to 21. And as well as his INR started going up from 2.3 to 2.8. And his enzyme started going up. His AST was around 445. So what could be the causes here? What are we dealing with? How do we take it forward? Could I ask Dr. Unnikrishnan, please?
Thank you, Dr. Dinesh. Basically, this is somebody who had a fairly uneventful transplant, big chap, who received a normal size graft, but the GRWR seemed to be too bad off. So the first thing to do in such cases will be to make sure that the surgical bits are okay. Like you image him to see if your inflow is okay, the poplin inflow is fine, whether your outflow is okay. But rather than having one of the major outflow veins going up, it may be that your aid reconstruction, or if you have an inferior hepatic reconstruction, whether that has gone off. The liver is not completely gone off, but there is some hit to the liver. So the first thing that I would think of will be to rule out technical issues that may be causing the graft to function poorly.
Absolutely, yeah. I mean, that's absolutely what we usually make sure. The arterial, there's no hepatic thrombosis, the inflow outflow tracts are okay, all those. Can I ask Dr. Mallika, from as a hepatologist, how do you see this patient? What do you do?
Yeah, so there are So the complications here starting immediately in the post-op from day one, and we see progressive increasing bilirubin, INR, and drain. So most likely these related to either structural issue, unlikely what like sepsis and rejection, those usually comes later on. So first early on the period when there is a graft dysfunction, yes, it should should focus mainly on the structural related issues in the liver, like outflow, inflow.
Absolutely. Okay, very good. Thank you. So what we do is, let's have an algorithmic approach. This is what we do in our unit. So whenever we see any patients with any graft dysfunction, the first thing, as we all agreed, is there a technical issues such as arterial, venous inflow, venous outflow, any bile duct issues going on. Then comes the infection, which we all know in India we deal with very often. That could be bacterial, viral, including COVID nowadays, and rarely it can be even fungal. The next problem could be immunological, which is probably rejection, either T cell or B cell mediated. And the last is the mixed bag of other miscellaneous stuff, which could be like drug-induced liver injury or small for size liver, or other extra hepatic issues such as LV, left ventricular dysfunction. All these things can contribute to early allograft dysfunction. So we have to be very systematic in our approach as how we do with that. May I ask Dr. Ajitab, how do you sort of in your practice deal with this sort of issues? If somebody has elevated
Dinesh, I think so. As you have rightly, like as we were just running the presentation of the patient pre-op workup, I think so. It would be important, since we were dealing with a person with a MELD score of 22, Although child score is B, I don't know whether it was driven mainly by creatinine. But yes, preoperative workup, and with although the donor is 30, young, with a graft weight of 755, but giving a low GRWR. So I think so. As a part of the workup, studying the preoperative anatomy, portovenogram of the patient in a proper manner, just to understand the size of the portal vein, any shunts present or absent, checking on the degree of portal hypertension, and like say checking on the spleen size, and like precisely because our GRWR is 0.7 and we are dealing with a person who has got a higher metabolic requirement. So as a part of pre-operative workup, checking on all these parameters would be important. Then once we open up, again checking the size of the spleen again, and in case if we feel that the spleen to liver ratio is or liver to spleen ratio is 0.5, then checking on the at the dissection phase the portal pressure, then having a decision based on algorithmic decision depending on whatever finding we get, whether we need to have a preemptive thing, whether we are dealing with somewhere portal hyperperfusion and dealing with it accordingly, either intra-op or immediate post-operative. Depending on the Doppler finding, if we feel that the portal vene's pressure is high, then immediately starting with say medical management for portal hyperperfusion if we have not tackled surgically intraoperatively.
Sure, thank you.
If I may come in here, Dr. Dinesh, a couple of things you've mentioned in your slide.
Yeah.
Two things I think, once you see bilirubin going up and all that, I know lots of us, not everybody does a time zero biopsy. So of course it might be a good idea to go and see your time zero biopsy, how was the graft liver, you know. So if sometimes there is all steatosis, fat and bad, poor quality of the liver, that is one. Of course, we have to keep that in mind.
Sure, no, I think it's a very valid point. Okay, so what we so let's go through one by one. So technical issues in this, and we had ultrasound, hepatic Doppler, and Dr. Naveen, what do you think about the hepatic Doppler? Do you think it's okay, acceptable, or should we do anything about it?
Yeah, I think it is okay. Only the portal velocity is not very high. It is okay, and the resistivity RI index is fine. 0.7 is okay, and they say, like, you know, triphasic flow is fine. There is no IHBR. So basically, nothing grossly wrong with the Doppler here.
Sure. And this infection screen was negative. The culture showed no growth, no evidence of sepsis, but the bilirubin continued to go up. The tacrolimus level was 7.3 on day 3 after the first few doses. And Dr. Mallikarjun, what do you think we should do? What the situation we are dealing with? Have we ruled out?
Achieving the tacrolimus 7.3 in within 3-4 days is very good. And then rejection in first 3-4 days is very, very unlikely. So we have adequate immunosuppression, and pattern is not consistent. We don't see often rejection so early in the transplant period. So I would like still bet this one on the structural thing.
Okay. Now, so this could be probably a drug-induced liver injury, because sometimes antifungals can cause delay. It could be small for size. Maybe it's rejection. As you said, it's slightly less common at this stage. So he underwent a liver biopsy at that stage, which showed portal tract hemorrhage, necrosis, and cholestasis. Dr. Unikrishnan, as from the surgical point of view, why do you think is biopsy useful in the immediate postoperative period, and why so?
I was confused that as a unit, we do not engage in early biopsies very often. But like you have shown here, in this case where none of the investigations, neither the imaging nor the infection screen or the other things contributed, the biopsy here was clearly that there could be an element of portal hyperperfusion, and the whole issue might be related to that. So I would defer the question to one of the other panelists who does routine early biopsies.
Actually, the same. Yeah, we also don't do biopsy so early in the course. But yes, since we were in a dilemma, in a clinical dilemma, suddenly the jaundice, the bilirubin was going up, and like ischemic reperfusion injury or something like related to the graft, if like say for decision making, maybe it must have been of help, but it's too early. We as a group don't believe in biopsy. Like we would have like to wait for or take a call depending on other parameters and then decide accordingly.
Sure, I mean, here it was done to know what, because TAC level is also reasonably okay and ultrasound, everything was fine. So just want to make sure there is no, we are not missing any hyperacute rejections in the scenario. That was the main indication, because as you know, the levels were going up, the bilirubin levels are rocketing high. Right, okay. So this gentleman is a 59-year-old gentleman, received a living donor liver transplantation. Graft recipient weight ratio was 0.7, and he had increasing enzymes, and the liver biopsy was suggestive of small for size syndrome. Now, what is small for size? How does it differ from what is the syndrome refers to? Can I ask Dr. Mallikarjun, please?
Yeah. So typically we define small for size means graft to recipient weight ratio less than 0.8%, where the liver volume is so small to receive the portal flow, which will end up in a graft dysfunction. It is because of increased portal flow, and there is some amount of graft injury either. And this is because of shear portal or sinusoidal injury because of large flow in a small graft.
Can I ask Dr. Ajitab, like small for size and the dysfunction, they are different. What is your experience on that?
So small for size is when we are apprehending dysfunction, like say when we are dealing with a person with a as per his standard liver volume, we are giving a smaller size liver and we are apprehending problems. And once he develops a dysfunction in the liver, is the small for size dysfunction or small for size syndrome, which is characterized by the definition which has been mentioned earlier in your, like say, as a part of early allograft dysfunction, in which there would be say the bilirubin would be high. Then would have high drain output of because of high portal pressure, and then would have the INR would not be correcting in the post-operative period. The problems may come up immediately after the surgery, or it may be a functional small for size later on because of graft sort of graft injury due to whatever reason. Patient may have a secondary or a functional small for size syndrome and may present with coagulopathy, cholestasis, and high drain output.
Because I think Dr. Dinesh, it's itself a misnomer. You know, it can be a functional. In bigger grafts also you can have small for size, partial non-function or delayed function, because it's basically the outflow and inflow, that portal flow, and how the outflow is, how the liver is getting congested air. As we saw, there is a lot of congestion in the liver. It's too early sometimes, like, first week, 3-4 days for it to develop. Actually, it's the second week actually when you can biochemically say that it's small for size. Initially, there are many more DDs, but small for size, in my opinion, which you always thought is a second week kind of a DD,
And also, small for size, sometimes it's a diagnosis of exclusion.
Correct, yeah.
There's
Exactly.
no rejection and no
Exactly.
underlying, which are more common problems, actually. Thank you. And then, so how do we manage this patient, actually? So what is going to happen to this gentleman who has this small for size problems?
वो मैं बैग भेजूंगी, पीछे का सामान खुला है क्या, दिखा जरा?
Could Dr. Unikrishnan?
बैटरी नहीं है.
Hello. Hello. Can you hear me? Hello.
Yes, sir. We can hear you.
So one of the panelists can answer. So what to expect, what's going to happen to the gentleman?
No.
So,
Yeah.
anyways, anybody who's having a small for size or suspected to have a small for size or allograft dysfunction, which could be on account of small for size syndrome, it would he would need a general what you say supportive care, would need to be supported well with for infection, would be requiring so that the further hit doesn't happen in the graft, so would be adequately immunosuppressed, then would have need a good nutritional support so as to promote the regeneration in the liver, and taking care of any infection complication which is generally higher because of translocation of bacteria in a situation like this.
Absolutely. Dr. Naveen, from the hepatologist perspective, you see these patients in the immediate post-operative period. What are the things that can run through your mind?
Of course, a couple of things that always it is, as a hepatologist, we have to watch the tacrolimus level. It really shoots up because there is cholestasis. And you see that with the same dose, the TAC level is jumping 8, 10, 15, 18. We've seen, because that's most important with cholestasis, the tacrolimus levels go up. So we have to keep that in mind. We have to change the drains, the fluid adequacy and all that, albumins and whatever. Antibiotics, of course, we have to, because antifungal cover has to be there, antibiotics broad spectrum, because they are very high prone for sepsis and they are in an inflammatory response syndrome. So basically they need to be managed as inflammatory and infective process. So need to be, we say they're like sitting duck for infection. That's what always we speak about in rounds,
Yeah,
so that has to be watched out. And fluid balance, albumin infusions takes care of drains, because what happens is this, if we don't change the drain outputs because they go very high, then you have AKIs, kidney injuries, then they'll add into dialysis, and that's when the sepsis part takes over. So of course, if you've diagnosed it by exclusion or however it is, you have to start the management and take care of all the things, because they start getting encephalopathy. Sometimes these patients have to be intubated early to give rest and all that. As we were speaking about, it becomes a subacute liver failure again. So you have to manage them accordingly.
That's right. So they behave like a multi-system disease. So you have to take care of other systems as well as a general measure. Dr. Mallikarjun, apart from that, is there anything you would like to do, or is there any other medications, treatment, therapies helpful in this situation? Because this gentleman has rising bilirubin. We are worried about losing the graft and himself. And is there anything else you're worried about? And
Yes. So there are couples of pharmacotherapies we can try, but definitely there is no good RCTs or studies on this. So there are a couple of like terlipressin or somatostatin, or even their beta blockers have also been used in these scenarios. But there is no adequate data to support it. But even in our clinical practice, yes, terlipressin, octreotide as and when required, and even beta blockers we use it. And another experimental therapy is like plasmapheresis. Yeah, again, it is like, as Naveen said, we are dealing with a type of acute liver failure, and there is a cytokine storm. And to control, like in any acute liver failure, you bridge the therapy till the liver starts recovering. So we do various maintain hemodynamics, do if required plasmapheresis, do terlipressin and albumin, and so various where we hold the liver so that it will give us time to recover.
Absolutely. So you have to make the liver to regenerate. So allow the test to settle down so that it can regenerate. In terms of the surgical approach, Dr. Unikrishnan, in terms of is there a role for at this stage any splenic artery ligation or anything like that would you do apart from these measures?
As Dr. Soling had induced it clearly in the previous talk, by the time we get to this level, we have already missed the bus regarding surgical intervention as a unit field. Because the initial hit on the small for size happens in the initial time perfusion where the endothelial injury and the free radical issues happen within the liver. At about day 7 or day 14, trying to go back in and adjusting the portal perfusion, I don't think will help us much. And by this time, most of these patients are ICU dependent and they are not excellent candidates to go back into theater for an exploratory procedure. We would probably give them best medical care and try to tide them over the period rather than going with a surgical procedure.
Sure. Yeah, that's, I mean, so this gentleman, we received a plasma exchange. As we discussed, this really effect is really not well established in this scenario. However, it removes all your pro-inflammatory cytokines, and reports are not very clear which way to sway around, but in this gentleman definitely helped. The problem is these sort of emergency situations, you can't really have a randomized control trials on this. So there are some studies on plasma exchange in early allograft dysfunction where it showed benefit, but again, these are smaller studies. Definitely it improves the survival rate in the early allograft dysfunction. And so we need to think about it in this critical situation to save the patient actually. So this gentleman received plasma exchange, and over a period of time, his LFT's liver function started settling, his bilirubin improved, and his INR improved, and again his transaminases improved. He started eating, mobilizing well, the drain output dropped. So overall, things have gone in the right direction, and he received totally 10 cycles plasma exchange, and the graft completely recovered, and he was discharged on day 30 actually.
So small query, Dr. Dinesh here, if I may ask for everybody's knowledge, is here in this patient, when we've done 10 plasmapheresis, when do you counsel the patient again for a retransplant? Because what is our window? Like, if the patient is not improving, 10 sessions of plasmapheresis is a lot. So if we are going ahead, when do we, I don't know, anybody's guess it is, so when do we actually tell the patient this graft might not recover, or if the trend is showing up, because these patients are they can get an infection and you will never get them back?
I think the trend overall, the direction which is going, the clinical improvement, the improvement in the
encephalopathy and all this.
Overall, the series, how things go, that I think that's important. There's no right or wrong answer, but the way things are going, I think that's most tell you the story how this patient is going to behave. Yeah, you're right. Actually, we need to know when to say this patient might require retransplantation. Yeah, we need to answer that question. So.
Dr. Dinesh, just before you go on to your next patient, I just would want to know, the patient had a high PSP to begin with. His right heart pressure was 44. That probably may have contributed because in a patient who's got a borderline graft, that slight higher right heart pressure can contribute to this small pulse size syndrome. And I think obviously papers on this are coming now, but spleen size does have a role in these patients. Because you had a good graft volume, you had a 700 plus graft volume. In spite of that, this problem did occur. So your biopsy shows a hyperperfusion injury. So probably the spleen size, which has not been mentioned here, may have contributed to it as well.
Sure, no, I think that's right. I mean, fluid management in the post-operative period is also quite important, because you shouldn't overload so that the pressure is already high on the right heart. So that should be maintained adequately. That's why it's a very multidisciplinary approach.
But I think so the hepatic venous flow was triphasic, as it was mentioned in the Doppler. I don't know, in case if there is a back pressure due to heart, I think so the triphasicity of the hepatic vein will be one, like phasicity of the hepatic vein on the Doppler would be one parameter which would give us an idea about the outflow, whether there is any concern with the outflow.
That's right. So post-operative, they were normal. Even the echo he had in the post-operative period was normal. So if you
Dr. Dinesh, just for a clarification, at what level of right heart pressure would you be concerned? We generally tend to go for detailed cardiac evaluations only if the values are greater than 45. What is your views on that?
Yeah, something very similar. We do that, and it shouldn't be portopulmonary hypertension. Obviously, in the pre-operative period, we give them adequate diagnosis and try and reduce the pressure before we take them for.
I think, Dr. Oni, there is one more thing. I think the cardiologists sometimes overcall it, and also we have to always make sure that the transthoracic does not correspond to the PA pressure sometimes. And thirdly, some cardiologists take it from RA pressure plus 10 or plus 5. So that we have to check with our cardiologists, because if they take it over plus 10, sometimes it's overcalling. So they actually, RA pressure plus 5 or 10 is their, they actually calculate it like that. So we had a lot of issues with the PA pressures, how do they calculate and all that. So we had done the math. So we have to always see what is their actual pressure, what they are getting, RVSP. They add the plus 5 or plus 10 to that. So we need to make sure what they are adding. If it's plus 10, it is overcalling.
Our cardiologist conveniently writes RVSP is 35 plus RAP, and we are left to guess what the RAP is.
That's what, intelligent people.
Okay, Dr. Dinesh.
Yeah, so the second patient is a 39-year-old gentleman, alcohol-related liver cirrhosis. He was on the cadaver waiting list for a year. Unfortunately, because of COVID, he couldn't get organ on time. Unfortunately, and he deteriorated with sepsis, gram-negative sepsis sort of mid last year, and developed acute on chronic liver failure. And then he underwent a living donor liver transplantation in December last year. The donor was his sister-in-law, was 35 years. Because of time, I'm just cutting short few things here. The cold ischemic time was 73 minutes and warm ischemic time was 58 minutes. This graft recipient weight ratio was 0.67. Graft weight was 622 grams. Lactate at the end of the surgery was 2.9. And the total pressure post-reperfusion was 10. In the initial post-operative period, preoperatively is believed as 10, and it went up to 12, and then improved to 5.5. But subsequently, it increased to 11.9 and continued to increase in the immediate post-operative period. And likewise, his LFT started, his liver enzyme started going up. His AST was 288 and ALT was 123. So it started going up in the post-operative 3 to 5. So how do we deal with this situation? Very similar algorithmic approach. Is any panelists want to say anything here? Like, or shall we?
Isn't this somebody where an intraoperative intervention regarding protocol modulation decision could be taken, should be taken? This is somebody who has a graft weight precariously close to 600. If you small vein, you go under 600. The functional liver goes under 600 grams. And the GRWR is also pretty low. Or do the other panelists feel?
But I think so the portal pressures which were mentioned, the delta really came down well. And I think so post-perfusion, portal pressure was 10, what is mentioned. So I think so that is what would be, like say, dealing with small for size would be one area. But I guess with low portal pressure, it wouldn't be.
Likely.
Yeah.
So similar algorithmic approach, we go through technical, infection, immunological, and miscellaneous. So his ultrasound Doppler was completely normal, and infection screen earlier it was negative. So that leaves us with immunological or other miscellaneous group of diagnosis. So he underwent liver biopsy on day 5. That showed T-cell mediated rejection as characterized by perivenulitis, central vein inflammation, portal tract inflammation, and bile duct injury. And and subsequently, he received pulse methylprednisolone, so 3 doses. And over a period of time, his bilirubin started to settle down. And optimizing his baseline immunosuppression, things started improving, and he completely normalized. So my question to the panelists would be sort of acute cellular rejection. How do we deal with that in your setup or in your experience?
So if I may answer here, of course, acute cellular rejection is that we see more often in, again, that 5 to 7 day first week later on, not the initial, once we've ruled out infections and everything. Very sick patients, if we say very sick patients, initial, early on, very seldom reject. It's kind of, we see if there's high melders who are very frail patients, they seldom reject unless they are alcoholics. So this is kind of a teaching point which we've learned over the years. I hope everybody agrees with me on that. Of course, biopsies are a must when you are diagnosing rejection. We should refrain ourselves from treating rejections with pulse therapy, because we are more at loss with infections than rejection. So it's important to do biopsies if we are in a doubt. If we cannot rule out anything else, of course, ACR early on, AMR is very, very less. And if it comes, if there is a antibody mediated rejection, it will be even more pronounced than the ACR. Having a decent TAC level early on and seeing if we can add, of course, tacrolimus is there, steroid, what dose we use. If there is no infection, keeping a level of 5 to 8 early on from day 2 or day 3, if there are no kidney issues, is a must to rule out and to keep rejections away. Most of the times, our patients do not need very supranormal TAC levels. If we keep a decent 5 to 8 level, they seldom reject. But of course, we have to keep in mind always one of the most important DDs of this thing, but which should never be taken upon or treated without a biopsy.
I think that's a very good
I think so. You're right. I think since we had noted that this patient had a clinical syndrome of ACLF, and that is the reason he was taken up for early transplant. And that is one pattern which we have noted, that whatever is the cytokines or the cytokines circulating in the circulation for a patient with ACLF, and putting them and pushing up their MELD, they, due to some reason, once they undergo a transplant, I would just like to get an opinion from other panelists and the chairpersons, that this is one pattern which is seen, that there's some degree of allograft dysfunction noted in the post-operative period. So in that situation, it really becomes paramount importance, and biopsy is important to know whether is there a recurrence of the same problem which the patient had in the preoperative period, and then a biopsy will give a solution. And I think so rightly done by the team over with y'all, Dr. Dinesh. And with biopsy, y'all confirmed that ACR was there. Otherwise, the pendulum would have tipped on the other side and would have created problems.
Absolutely. I think it's very important to diagnose there is early rejection or not. Obviously, if you're dealing with sepsis, the treatment is completely in the opposite direction. And in terms of Dr. Mallikarjun, any other inputs you'd like to?
Yeah, so usually pulse therapy in the so early period we don't use. Usually we focus on optimizing this, as Naveen said. There is always a risk of infection. And in this as a given patient also, enzymes are not terribly bad. Yeah, of course, bilirubin is going up. Rather than pulsing, I will be more interested in optimizing little bit, increasing steroid and going up on the TAC. And also,
since the diagnosis of ACR was confirmed, if the biopsy was not done, then I agree. But as the patient had a low GRWR, and as we discussed in the previous case, that preventing further hit to the graft, and I think so doing an early biopsy was important here, and getting a confirmed diagnosis, because I'm sure with this ACLF, the induction steroid must have been slightly on the lower side, and probably that must have tipped off. Although it's too early to get a ACR, we haven't seen ACR so early, but yes, once you've had the diagnosis confirmed on the biopsy, and I think
exactly. Once you've done a biopsy, you are stuck. If you not have done a biopsy, then it's okay. We'll pick the
then there was a point
you
of
can
discussion.
tweak the TAC levels, keep them around 10, and see how the response is. But once you've done a biopsy, you're committed, and you see a ACR, you have to salvage the graft.
In severity of rejection, everything matters. Otherwise, if you lose the graft, and with this high bilirubin, it's all going to cause.
What was the dose of steroid used in this case?
We used 500, I think, 500 milligrams.
So I think all the centers now have compromised on their steroid use in induction as well. Pulse. Most of the, because we've learned from our experiences, like half the dose from whatever West uses, and it has worked out well. Actually, 500, if the response is well, then you can go to 250 as well, and we've seen good responses if it is early on. It's not a tough rejection.
Absolutely. Now I think the steroid less induction, and then even not trying to maintain too high tech level, just tailoring the immunosuppressant depending on the patient's requirement. And I think so whatever is the values which we get in the post-operative period, and then tailoring the immunosuppressant as per the requirement of the patient.
Agree.
I would just request to please kind of try and wind it up faster.
Yeah, sure.
We're overshooting that time.
Yeah, that's last couple of slides. So earlier allograft dysfunction, there are a couple of 2 or 3 risk scores formulas have been derived. Most of them are logarithmic, but in real life, not sure how many of us will use this, but we go by the clinical picture. So this is the algorithmic approach as requested by LTSI. It's here. Anyone could add on to this, any of the panelists or the chairpersons could say something about it.
I know we are short of time here. Small thing I wanted to ask Dr. Dinesh, initially, the first slide, the first patient, the slide is still there, LV dysfunction. He had a LAD which was 60% blocked, but his DSC was normal. So if your DSC is normal with a 60% thing, we always have to keep in mind some kind of LV dysfunction or we've seen these Takotsubo's syndrome and all that couple of times now, actually stress cardiomyopathy in specifically these patients who actually have a bad LV. So that in mind with this cholestasis and all that is always important. Of course, you mentioned that there was an echo and everything done. So actually we sometimes get carried away and we don't look at it. We don't do the echoes later. Might be an important thing to do in such patients.
I think that's where this sort of systematic approach might be helpful and guide us how to manage these patients in the early postoperative period, actually. I would like some inputs from the chairpersons, and if not...
I just had one comment, if I'm allowed. Dinesh, can you hear me?
Yeah, sure, yeah. Yes.
Yeah, Dinesh, I wanted to know, usually for early graft dysfunction, all that you said was what we look at, but I was surprised you wanted to keep biliary so early in the case that you were talking. Would you, what exactly, why did you want to keep biliary in your approach?
In terms of?
Like you were talking about the case so early, first week in the enzymes and all. And then you said you wanted to keep biliary in your technical. So what?
Yeah, if there is any bile leak, sepsis related to that.
But bile leak wouldn't actually end up giving rise to at least I've not in my experience seen a graft dysfunction with a bile leak. That would come in infection sepsis. That's I can understand. Venous inflow, outflow, I can get it. But biliary technical as first. That's what I was just wondering how exactly you wanted to put it as an early graft in your scenario.
No, ma'am, bile leak can present as cholestasis as well as transaminitis.
Yes, so therefore, that's what I'm saying. Sepsis, I'm not, cholangitis and sepsis is two of the story, which will come in infection. But he wants to put it as the first week early allograft. So normally, at least when I talk about it,
probably surgeons
I don't teach that in there. I usually call biliary in my teaching as infection sepsis related to cholangitis, leaks, etc. I say. So is it the same way you're thinking, or is it something that I'm not in page?
Similar, but probably maybe Nirav, what is your thought process on that?
Yeah. So biliary will be a part of the algorithm for early allograft dysfunction because, you know, I mean, like a leak may be responsible for a graft dysfunction or an inappropriate stitch where it causes a narrowing of the bile duct may be a problem. So one has to rule it out definitely as part of the algorithm. My only thing is in this whole algorithm, I think your size of the spleen, as I was mentioning earlier, is missing. I think it has a very important role in small pore size syndrome. So I think that needs to be also taken into account. The volume of the spleen and its ratio to the graft volume.
Can I interrupt? Can I say something?
Yes.
Dinesh, very nice. Actually, I enjoyed both the presentation, both the cases. Just about the definition, actually, there is a controversy about the definition. And when we look at the definition of early graft dysfunction, actually, it excludes technical, immunological, and biliary complication. So when you say early graft dysfunction, when you're defining early graft dysfunction, you are actually excluding all three of this. And then you say that this is early graft dysfunction primarily because the graft is not working. So you exclude technical complication, you exclude immunological, and you exclude biliary complication. And once you excluded those three, and still you got that definition is being satisfied, which is again a controversial definition because on day 7 may not, on a single reading may not be actually right definition to put in. And so that's why the ideal definition in literature about early graft dysfunctions. We have tried to, sorry, yeah.
And also we
have tried to put a new definition, which is, this is an accepted paper now. I'll actually share this paper once the PDF is out, where we try to redefine the early graft dysfunction in live donor liver transplantation, because that definition has been picked up from DDLT setting and that may not be applicable in live donor setting. So we have actually tried to derive a new definition, and I've shared it with some of the members in LTSI. And once the PDF of that paper come, I'll actually share with others as well. So that's basically based on a dynamicity of over the 5 days. So if the parameters like bilirubin and INR remains elevated after day 7 for more than 5 days, then what happens is you're trying to exclude other causes as well, like sudden sepsis or something which has happened and it has not been treated by 5 days, then basically you got an underlying graft problem. And that is actually, that these are a proportion of patients who actually are not going to do well, and you need to start thinking at some point maybe whether we should offer retransplant to them. So that's how the literature defines it. Okay.
Excuse me, Dr. Pamecha, you just said if there is sepsis and it causes cholestasis, so would you suggest a retransplant in that patient?
So what I'm saying is that's the problem with the definition actually, that Althoff's definition actually just take day 7 single parameter. It doesn't have the dynamicity. Okay, so if you got a sepsis as a cause, sepsis can be both. Sepsis can lead to graft dysfunction and graft dysfunction can lead to sepsis. But if these parameters are satisfied over days, consecutive days,
I think there are a few papers also, Dr. Pamecha, which actually say day 1, 3, 7, 9, 14, and 24.
There are some dynamic scores.
Yes, there are some dynamic scores.
Those are scores actually. Again, those are the scores which have been derived. But in terms of when we start defining early graft dysfunction, that's the problem with Althoff's definition actually. And you will be surprised actually the way Althoff's definition was actually taken out from DDLT. The way I know the literature is, there wasn't actually a big analysis done to derive that definition. It was more of an this one that if this are the parameters, then that's how it
is. I think we can see Dr. Nirav getting restless. We have to stop.
I think we have to conclude because I think Dr. Nijal Hiten is also online now.
Yeah.
So
okay.
I think
it was an amazing presentation. I must congratulate.
Thanks a lot, Dr. Dinesh. Thanks everybody.
Thanks everyone. Yeah.
Brilliant.